given us practical strategies to address challenges in clinical practice and improve patient outcome. Moving on, it is my distinct honor to welcome Professor Dr. Shahid Javid Akhtar, a highly esteemed and dignified professor of dermatology with extensive expertise in skin-related conditions. He will enlighten us today on an important but often underappreciated topic, the cutaneous manifestations of diabetes. Please welcome Professor Dr. Shahid Javid Akhtar.
For the panel of experts, especially my ex-principal and the first Vice-Chancellor of Festival Medical University, honorable guests, ladies and gentlemen, Assalamu Alaikum. In the next 10 to 50 minutes, we will look on some of the cutaneous association of diabetes mellitus. Next one. We're grateful to the organizer, especially Dr. Amish Azad and Dr. Ijaz Ahmad for their excellent organization and kind hospitality. Indeed, their untiring efforts made this conference a successful event. We always remember our body teachers, late Professor Tahir Said and Dr. Manzoor Hassan, who are responsible for the birth of next generation of dermatologists in Pakistan. Currently, we have more than 60 to 70% of the dermatologists who are working in Pakistan. Either they are directly students of these great legends or indirectly the students of their students. We always pray for their highest rank in Jannah. That is the chronic metabolic disorder. It affects various organs, starting from brain to the GIT, and skin being the largest organ of body. That many times reflects this chronic metabolic sequence onto the surface of skin, and that's why you can always look onto the skin to see associated changes. And by and large, the microangiopathy is the main, the dominant event that is responsible for various end organ damage. And the main reason is the hyperglycemia that causes increased production of advanced glycation end products, and they are deposited in the blood vessel wall, and that leads to the microangiopathy. And this microangiopathy reflects on the surface of the skin by diabetic dermopathy, redness on the skin, and erysipelas or redness on the lower part of the limbs, leg ulceration, and the gangrene. And these are the changes which are directly related to the microangiopathy, and that's why we can predict by seeing on the skin that perhaps this person needs screening for retina for suspected nephropathy. Diabetic dermopathy classically presents as brownish red spots on the chin, and these are because of microangiopathy. And although they are asymptomatic, but many of the patients, they may concern with these cosmetic disability. Although they are asymptomatic, they often leave these type of scar, and sometimes this scarring may be very extensive one and leads to atrophy. And if anyone with these, it becomes mandatory for the practicing physician to look for retinopathy and nephropathy, since these both, rather three, they are because of microangiopathy. Although the dubiosis or red of the face is very well described in literature, but that is not common in a racially pigmented skin. It's a common ailment in racially white complexion individuals, but we usually, because of high concentration of melanin in our skin, do not see this type of feature, although documented as 5 to 10% of the patients with type 2 diabetes may be having this sort of ailment. The redness on the lower limb need not always be because of cellulitis. Many times it's only because of autonomic neuropathy, and there is stasis both because of the structural changes in the vessels and the functional impairment of blood flow because of the autonomic neuropathy. These lesions, they present as cellulitis-like features, and whenever a patient presents with these changes, instead of straight away going to the injection for suspected cellulitis, we have to go for marker of the infection like C-rectoproteins or ESR and blood count before embarking on the antimicrobial therapy. The most feared one, this diabetic foot and the diabetic ulcer, is a multifactorial end stage, mainly because of neurological damage. The skin become hypoanesthetic, and there is a start of callus formation and fissure formation, and the process goes on. Since the lesions, they are asymptomatic because of loss of pain sensation, the patient go on doing their routine work, and they end up like this one, where there is involvement of the bone and leading to osteomyelitis. Although initially the infection is not the culprit, but then ultimately that is the osteomyelitis that is difficult, and sometimes then we have to resort to amputation of the digits and even to the foot also. It's a complex phenomena, not only because of microangiopathy, but there is macrovascular disease involvement also. There is neuropathy, and both the autonomic, motor and sensory as well, and then the routine daily trauma, and all these cascade of events ultimately lead to loss of the digits. And that's why we have to advise the patient before they end up with this stage, which is difficult to treat. As a preventive measures, it's become mandatory for every treating physician that they advise their patient to take care of good personal hygiene, apply plenty of moisturizer, and inspect daily the interdigital area, and file the nail properly before we end up with a difficult to treat diabetic foot and diabetic leg ulcers, which is indeed a difficult task, since the process is continuous one, chronic one, and need multidisciplinary approach. The especially important one is the pressure offloading in case of established diabetic foot, since the main problem is the hypoanesthesia or anesthesia, and these ulcers, they are ischemic one. They start as callosity, and then since the patient continue to walk, they go on doing their daily exercise, and the lesions will not heal. The especially important one is the pressure offloading, and you can do as a family physician very well with the very economically available these plaster of Paris, especially designed to offload the pressure. Carbuncle on the nape, classical presentation in case of type 2 diabetes, especially on the back, and many a time would start to treat them with oral antibiotics. But since the absorption is not very good with oral antibiotics, it's because of Staph aureus infection. So whenever any patient presents with this sort of carbuncle and diabetic, you need to give intravenous antibiotics and the first generation antibiotics to take care of Staph aureus. And when there is localization of pus, obviously you have to incision and drain. So wherever there is a pus, you need to drain. The penetration of antibiotics in pus is minimum 1. But bacterial infection, not always because of these systemic diseases like diabetes or immunosuppression. we as a dermatologist and as a family physician, we see very extensive bacterial infection like this, especially in young children, and in our OPD, majority of cases they are because of scabies. And this is the localization of lesions to the interdigital area, and this is the classical burrow of scabies. And so the localization of lesion to the interdigital area gives you clue that this is probably the scabies underlying cause, and this is the main culprit. Currently, we are saving 50 to 60% of the patients who present to dermatology OPD. They do so either directly because of involvement of this culprit, small ectoparasite, or indirectly since the patient's excoriate their skin, they present with secondary extensive bacterial infection, urticaria or eczematous lesion. And this is the culprit. Scabies is endemic in our setup. Herpes zoster, although it's a self-limiting disorder, but in cases of diabetes, the incidence is slightly high, and especially in cases with diabetes, we many times come across with necrotic lesions. But nowadays, many of these necrotic lesions, they are not because of underlying metabolic disorder. Many of these patients, they have been given injection steroids since it's a common habit in our practice by requires that whenever there is any skin lesion, they go for an injection of steroids and lincomycin. And when you treat a viral infection with steroid, the necrosis extends. Since there is a very economical availability of antiviral nowadays available, so instead of going to the injection of steroids, it's better to go for the specific therapy. Type 2 diabetes is many times associated with metabolic disorder, and that was very extensively discussed and will also be discussed in the next session. I will not go into details of metabolic disorder, but in case of skin, we can see some of these presentation of metabolic disorder. This is the acanthosis, or we call it pseudo-acanthosis nigricans. The velvety, thick, hyperkeratotic lesion, usually involving the flexors and many times on the face, and they may be taken as cases of melasma, but these are the cases of acanthosis, and underlying cause is metabolic syndrome, and that is a indicator of insulin resistance. So any patient with obese who present with these sort of lesions like this one, you have to go for their glucose profile and treat the underlying cause. Skin tags, or we call it ectocordon, they are papilliform projections, again because of insulin resistance, the growth factors, and they lead to hyperplasia of these lesions, although it's a cosmetic problem, but again an indicator of insulin resistance. And whenever any patient presents with these sort of lesions, apart from doing the electrocoagulation or cutting of these lesions for cosmetic reasons, we have to treat the underlying cause, which is usually the insulin resistant. Eruptive xanthoma may also be the presentation indicating the hyperlipidemia. Although it's a very uncommon skin condition, but we usually see the xanthelasma, that is deposition of fat in the periorbital area. Although these eruptive xanthoma they are indicator of the hyperlipidemia, but these xanthelasma, they are not. In case of xanthelasma, there is localized deposit of lipids, and the majority of these patients, they have normal lipid levels, and you need to give topical therapy, and they will not respond to lipid-lowering drugs. You need to give either the local destructive therapy like cartridge, electrodesiccation, or it's better to excise with electrical excision. Lipodystrophy, another complication not commonly seen nowadays. The lipodystrophy, it's immunologically mutated to the old insulin, but with the new generation, it's very less likely, and the individuals who do not rotate the injection site, the lipid hypertrophy is common event, and that's why you have to advise to patients to rotate the site of insulin injection. Otherwise, when there is lipid hypertrophy or hypertrophy, the absorption of insulin will be delayed, leading to lower systemic effects of insulin. Necrobiosis, lipoidica, again asymptomatic waxy plaque on the skin, especially on the shin, and some of the patients may lead to this side of necrosis in a few patients. It's because of diabetes and granuloma annulare and other form of granulomatic disorder, and about 10 to 15% of the patients, they have underlying diabetes. And luckily it's a self-limiting disorder, that's why you need not to do any specific therapy. Type 1 diabetes is often associated with other autoimmune disorders like vitiligo, thyroid disorders, especially hypothyroidism, and even Addison's in 0.5% of the patients. So if anybody presents with type 1 diabetes, you have to screen them with this sort of feature. Increased stiffness of the fingers, and even the increased glycolation of the collagen and cross-linkage of the collagen in the trunk can lead to stiff skin, and that is again is commonly seen in type 2 diabetes. Diabetic bully develop because of various reasons, and many times they are spontaneously remitting, and you need not to take any antibiotic if you see any lesions. And the last one, the dryness of the skin because of microangiopathy, because of increased glycation of the collagen, the skin becomes dry, leads to fissure formation. Patients scratch their skin, the barrier function is disturbed, and then they end up with the second bacterial infection. So always advise, especially in winter, and especially in the persons who are above 40, to apply some of the moisturizer. There are plenty of moisturizers available, starting from 200 to 20,000 per bag, like Dove, and you can name any brand. But the most economical and very effective one is if you mix the readily available petroleum jelly with coconut oil. Coconut oil has got its own anti-inflammatory, keratolytic and soothing effect, and when you combine these in 50-50 and apply onto the skin when the skin is still wet. This is a common video which we present, which we share with our patient and ask them to apply this ointment onto the wet skin. The idea is to keep the skin moist, and when they apply this ointment onto the wet skin, the water on the surface of skin is entrapped, the trans-epidermal water loss is decreased. You can apply, and always ask them to do not rub against the direction of hair follicle, otherwise they will end up with folliculitis. And then you can rinse off the excessive petroleum jelly with the water and then pat that area dry. Thanks for listening.
Thank you so much, Professor Dr. Shahid Javid Akhtar, for your enlightening presentation on the cutaneous manifestations of diabetes. Your expertise has provided us with valuable insight into recognizing and managing these conditions, which are critical for comprehensive patient care. It is now my privilege to welcome Professor Dr. Lyallpur, a renowned personality in the field of medicine and gastroenterology, with vast experience in teaching, training, and research. He has been a leader in innovative and endoscopic procedures, and it's indeed a great honor for us that he has spared his precious time for this academic session. He will be enlightening all of us on a very interesting topic, transforming weight management with liraglutide. With his extensive knowledge and clinical experience, we look forward to learning more about the impact of this treatment in managing obesity and related metabolic challenges. Please welcome Professor Dr. Lyallpur.
Thank you very much. I'm really delighted to be here.